Hello everyone, welcome to 5 Mark Short Note series. In this video, we will discuss about Bartholin cyst. So Bartholin glands are paired mucus secreting glands located at the posterior part of the vaginal vestibule. Obstruction of the duct leads to mucus accumulation and cyst formation. And common benign lesions are seen in reproductive age women. Coming to the epidemiology, age group commonly affected is 20 to 40 years and it occurs roughly in 2% of the women, which is usually unilateral, and it is very rare post-menopausal, and if it is there, we have to suspect malignancy, and there will be recurrence of 5 to 10% after drainage in women who have already got a Bartholin cyst. Coming to the surgical anatomy, the gland size is roughly 1 centimeter in length and it is located in 5 to 7 o'clock position at the vaginal introitus. The ductal length is 2 to 2.5 centimeter open below the hymenal ring. It is supplied through internal pudendal artery and the venous drainage is through internal pudendal vein, and superficial inguinal nodes are the lymphatics that supply this Bartholin's gland, and it is supplied through pudendal nerves. Coming to the etiology, Bartholin cyst forms due to the obstruction of the gland duct, which prevents mucus secretion from draining normally. The retained secretions cause cystic dilatation of the duct. The common causes include inflammation of the duct due to sexually transmitted infections like Neisseria gonorrhea and Chlamydia trachomatis, and trauma may occur due to intercourse, childbirth, or surgery. And there will be chronic vulvovaginitis and mucosal edema or fibrosis leading to ductal blockage. If the cyst becomes secondarily infected, it can lead to Bartholin's abscess. Coming to the risk factors, sexual activity. So, if there is any frictional trauma and exposure to infections, poor perineal hygiene, recurrent vulvovaginal infections, previous perineal trauma or surgery, and multiple sexual partners leading to increased risk of Neisseria gonorrhea infection, diabetes mellitus which predisposes to infection, and any immunosuppression like HIV or corticosteroid use. The commonest organism is Escherichia E. coli, and STI related like Neisseria gonorrhea or Chlamydia trachomatis. Others like Staph aureus or Staph ecalis or anaerobes also can cause. Mixed infections are also quite common. Coming to the symptoms. Usually it will be a painless swelling near the vagina, and a discomfort during walking or intercourse might be there. Pain and fever will be there if it is infected. Swelling at the posterolateral vaginal introitus, and it is smooth, fluctuant and cystic on palpation, non-tender if uninfected, red, tender and warm if abscessed. Swelling displaces the vaginal orifice medially and usually it is unilateral. So coming to the differential diagnosis, Bartholin's abscess, painful, tender and inflamed swelling along with fever. Cyst of canal of neck, it will be more anterior, translucent and reducible. Vulval epidermoid cyst, there will be more superficial, not typical 5 to 7 o'clock position. Scaneous duct cyst, it will be situated near urethral meatus rather than vaginal introitus. And vulval carcinoma, this will be very hard, irregular, ulcerated lesion in the older women. Coming to the complication, it might lead to abscess formation, recurrence after drainage, cellulitis of vulva can also be there, and there will be a rare malignant transformation of adenocarcinoma. So the investigation is usually done through clinical, the diagnosis is made mainly through clinical, but swab for culture and sensitivity can be sent, and STA screening if there is any gonorrhea or chlamydia suspect, biopsy if there is recurrent or post-menopausal cyst to mainly exclude carcinoma, wherein this vulvar carcinoma can be a differential diagnosis. So asymptomatic is mainly observational. Symptomatic marsupialisation can be done, and infected cyst or abscess, then incision and drainage plus antibiotics. Recurrent postmenopausal, then there is excision of gland and histopathology. Management of abscess, incision and drainage, broad spectrum antibiotics for E. coli and anaerobes, sitz bath as well as analgesics prescription, marsupialisation after infection subsides. So prognosis is excellent, though there is a chance of 10% recurrent if there is any incomplete drainage. Maintenance of genital hygiene and treatment of STIs early is good, and safe sexual practices to prevent infection is recommended. So to summarize, it is a cystic swelling formed by the obstruction of Bartholin gland duct leading to mucus accumulation, and it is common in sexually active women in the age group of 20 to 40 years, which is usually unilateral but very rare postmenopausal, and if it is there, we have to suspect malignancy first of the vulval carcinoma. So the gland is situated at 5 and 7 o'clock position of vaginal introitus, and the duct is 2 to 2.5 centimeter in length, supplied by internal pudendal vessels and drained to inguinal nodes. Coming to the etiology, the duct obstruction due to infection like E. coli, gonorrhea, and trachomatis, trauma, or fibrosis can happen. Risk factors include sexual activity, poor hygiene, diabetes, immunosuppression, perineal trauma, recurrent infections. So clinical features include painless cyst swelling in lower labia majora, discomfort during intercourse or walking, pain and fever if infected. Differentials include Bartholin's abscess, cyst of canal of neck, Skinny's duct, and vulval carcinoma. Diagnosis is mainly through clinical, but swab culture and STI screening is recommended, and biopsy if recurrent or postmenopausal cases. Management is mainly through observation. Marsupialisation is done for symptomatic cases and IND for any recurrent cases and postmenopausal cases. Prognosis is excellent, though 5 to 10% recurrence may be there, along with a rare chance of malignancy, but it has to be ruled out in older women. Hope you have learnt in this 5 mark chat note series. Thank you for watching.